So good evening, everyone. Today, the topic that I would be talking on is critical alerts in clinical laboratory. Now, why are they called critical alerts? And in a clinical laboratory, why is it so important to ensure that we inform the clinicians on these? So what is an alert? An alert is letting people know there is something serious. Please be aware that this value is high for this patient, so that they will go ahead and start treatment immediately. The reason it is critical is if we don't start the treatment immediately, the patient's condition will critically deteriorate. Since the values are very, very low or very, very high, and they are in the critical range, it is very, very important that we alert the treating doctors immediately on the patient's condition. So that is how the word critical alerts came in. Now coming to the role. The role of critical values in patient care. Why is it so important? It's because it helps in early detection, and critical values serve as alarms. Like I said, we need to send out an alarm that there is a patient out there who is deteriorating. His values are very, very high or very, very low, and he is in a critical condition. And that critical condition, if not addressed, will be life-threatening. So the role of critical values reporting, because they are life-threatening conditions. And these values help and guide the professionals, healthcare professionals, what is the right treatment plan. And also to assess the patient's risk and the progress he is making, because over a period of time, if his values continue to be raised, then it is an indication that the patient is deteriorating. So for us in the lab, it might be just a number, but that number is the value in the patient's body and giving an indication to us that all that is happening inside his body, and which we need to ensure that we address it immediately so that he doesn't or she doesn't deteriorate. Now, how do we go about ensuring critical patients? Once a sample is analyzed, alerting. But how do we ensure that that sample itself is analyzed very fast? So the way forward is, whenever a clinician thinks that this patient is deteriorating, he is critical, then ensure that they put an emergency sticker. And this is something that we can do in all our labs. Just ask them to put one small red sticker on the tube. So the moment, in the hundreds of tubes that come, the moment we see one red sticker on a tube, that will be the first one which will pick up. It will bypass all the cues and it will go into the stat mode of analysis. That way, we are reducing the turnaround time by which we can give a report. So remember, critical alerts, patient is critical, and that means it's an emergency. And so an emergency sticker or red color or any color which you feel, red is very vibrant and it stands out. So we choose red and stick it in a place, not on the cap, but on the tube, because when the cap is removed and the tube is put into the machine, it will get lost among the numerous number of tubes. So ensure that that sticker is kept on the tube. It doesn't cover the barcode or the demographics of the patient. So that should be the location in which the sticker has to be. So one, we know that patient is critical. We know that we have to address these samples on an emergency basis, and we are ensuring that we put a sticker on them to and see that it is fast tracked. Next, if I have to introduce critical alerts, what are they? Critical alerts are actually abnormal test results. They are abnormal test results that potentially are life-threatening for patients. And why are they important? As I told you, early detection of clinical alerts can help healthcare providers take timely interventions and prevent adverse events, patient from deteriorating. And how are they identified? Based on this severity. One should understand that how do we say this is critical? How do we say this is normal? How do we say it is low or high? The biological reference intervals which are there. Now, what are biological reference interval? They are the values, normal values in the patient body. That varies depending on the age of the patient and the sex of the patient. A male patient at 18 years will have some normal values. A female patient of the same age can have different values. So having one standard value will not suffice. If you have adult reference ranges for pediatrics, then we are going all wrong. So pediatric reference intervals for pediatric, geriatric reference intervals for geriatric, normal reference intervals for normal age patients, male, female. Once we put those reference intervals into the system, then if you have LIS and you have a computer, then what happens? You can define which is normal, which is low, which is high. And when it is more than high, when it is critical, you can label them critically high. And when it is critically low, we label them critical low. So this is a spectrum. You have critically low, you have normal, you have high, and you have critically high. This is the spectrum of remarks that we give on the reports. That is how, whenever a value comes and it falls in which range, if it falls in the low, remark comes low. If it falls in the high, remark comes high. Falls in the critical high, it is critical alert. Critical low, it is an alert. How many of you all have understood this till now? Type in the chat box if you've understood. Type why if you understood till now. Why is reporting it to the doctors important? What are critical alerts? When do you say it is a critical alert? And how do you ensure that every patient actually the biological reference intervals is correct for the age and sex? Only when you have those parameters set, then only the critical alerts which you define will be actually relevant. If you've not defined, then it will not be relevant. And if you do not address the sample, do not put a sticker, then also we are not addressing it accurately. So far good. Now coming to how do we classify them? Now I told you biological reference intervals, normal values, low values, high values, critical, high, critical. Now in this also, we have a classification. We have class 1 critical alerts. That means immediately they are life-threatening and immediately corrective action should be taken. High potassium. If the action is not taken, then patient will die. Those are the values that are very, very important, and they come under the category of class 1. The next is class 2, where some results are potentially life-threatening. They are borderline. They are not to that level where the patient can die if not treatment, but over a period of time, he will progress to that level. And that is class 2. And class 3, the result is not immediately or potentially life-threatening, but further investigation may be warranted. Like sometimes you have chronic renal disease, critically high creatinine, but still he is not in danger, but we have to address it. So they all fall under class 3. Class 1 is emergency troponins, high potassiums. Class 2, where if like glucose, very high glucose, if they don't address it, he will go into diabetic ketoacidosis. So that is how you classify class 1, class 2, class 3. Understood classification of critical alerts? Next. Now, I'll give you some examples. Say cardiac, abnormal cardiac, troponin, CKMB, ECG changes, all these are alerting the doctors. Now, critical alert doesn't mean only lab values. Anything, be it the monitor that he is connected to, and if his pulse is going up, his BP is going down, his ABG is abnormal, all those are alerts. For us in the lab, we stick to our lab critical alerts. But for a doctor, all these are critical alerts. Neurological, whenever you get a CSF sample and you know that the values are high, that is why CSF sample is so precious. And if something happens to the brain, permanently there will be damage. So they are alerts that we need to look into. Hematological, thrombos, if there's a pulmonary embolism, if there's thrombocytosis, transfusion reactions, all of these are the different types of alerts that you have to think of. Not just a couple of alerts. You have to think about the organ, you could think about the value, you think about what is going to happen to the patient if this value is not reported to the doctor immediately. So when you see a test and you see the values high, automatically you have to relate troponin is to a patient, to his heart, he's having an MI, we have to stop, we have to tell the doctor so that he gets treatment and he doesn't die. That should be the way of our thought process. Now, what are the effects of critical alerts on patient care? Increased risk. Patient will develop complication or suffer organ damage if corrective action is delayed or ineffective. Like I said, if he's having MI, we don't treat him, his heart he'll die. Second, the care which we are giving is very poor quality. And all these delayed interventions will impact and cause harm. So critical alerts are considered as medical errors and we can land up in a lawsuit. We can land up in a lawsuit. But that is the other extreme. As doctors, as hospital staff, don't you feel that it is somebody's mother, brother, sister out there? And if it is our people, won't we want the reports fast? Won't we want the care fast? Every patient is somebody's mother, brother, sister. So if we understand and put ourselves into their position, then the urgency will start coming in. Doing it for the sake of doing, because legal implications, you under force will come, but inherently we should have that we should report. Now, how do we manage? How do we communicate? Those are umpteen number of challenges in managing critical alerts. One is, if you're not picking the sample in the numerous number of samples, it'll get lost. the high volume. Second, if so many parameters are high, so many patients' values are high, then what happens is it becomes a routine for us. And that empathy factor is lost. But if we again go back to what I said, if we just link the test to a patient and a patient family, then we will say, yes, even if it is frequent, we need to let you know. Then, how do we make it a habit? Workflow integration. How do we integrate this is very, very important because it requires effective communication. And it is not like I'm calling from the lab, I know the doctor, I just pick up a call and I talk. No, in a hospital setting, we have so many patients. We don't know which patient is being treated by which doctor. How do we tell the doctor who is treating them what is the value? So we need to find ways in which the right information goes to the right person at the right time. And many times we find because of resources constraint, managing critical alerts is always not at the optimum level. But we need to value patients' life and we need to ensure that we prioritize this. When we prioritize our task and channel it to this, then it is a life saved. So even when we have resources constraint, there are some samples we can always, another 10-20 minutes delay is not going to harm the patient. But the same delay of this will definitely cause a lot of harm. So whenever you're reporting, whenever you're thinking, whenever value is high, keep this in mind that the huge number of volumes of alerts cannot be taken lightly, and we need to address each and every, because it's not just another value, it is a person out there. Visualize the person with the value. Now, how many of y'all it was a bulb on moment for y'all? It is a different thought process. All of y'all, please type yes or no. Why for yes? I want to see. I want to see the chats buzzing, whether I want you all to start typing out. Yes. Type out in the chat box. It gave you a different thought process of how, when you train your team members also, that they have to look at the value and immediately they have to picture the patient. When automatically you picture the patient, then you will right then and there make the effort to call and let them know. And you will find ways, if we are not able to reach them, you will somehow find the way to let them know. And even when there is very less resources, you will prioritize. Clear till now? Done. So there are challenges. Every lab has challenges. But there is a way out also for these challenges. Now, what are the strategies in which we can minimize reporting the critical alerts, that only true critical alerts go out? We don't unnecessarily send out false critical alerts. And if they are critical, really, how do we go about doing it? So one is, whenever there is a alert, first we need to know that that value is correct. And for us to know whether the value is correct, we need to have our QC in place. If we don't have our quality control in place, if we don't have our reagent in place, if we don't have our equipment all set, if we don't have our reagent optimum, we don't have our calibration properly. If the calibrator is deteriorated, the graph is gone and the value is wrong. If the reagent is deteriorated, your value is wrong. If the machine is not working properly, the value is wrong. And when a value is which is wrong, then your critical alert is also wrong. Maybe we are not reporting some critical alerts. And if it's showing a high value, then you're saying it is a critical alert. Now, troponin 0.1 to 0.2 to 0.3, there's a huge difference. You might think it's only 0.1, but that is between life and death. So how do we ensure? We ensure that we have electronic media now. We have phones, we have WhatsApp, we have telephones. Using these send out methods. Otherwise, if there is an EMR solution, write in the EMR solution in your software, ensure that it's all red color. The moment you're releasing the report and you find a red, that means you know it's an emergency sample. And you know when you click on that first, you will find critical values. When you know that there's a critical value, you call them. Then you note down whom you called, when you called, what time you called. So electronically, you can transmit it. And remember, it is all our collaborative effort, right from the patient who is drawing the sample, person who's drawing the sample, to sending it to the lab person receiving it, analyzing it very fast, putting it into the machine, bringing out the values, seeing that they are very high, calling them, alerting them, informing the doctor in turn taking action. Unless all of us come as a team, only then will the patient and the doctor acts on it timely. Then only the end result is a positive result. And only then will it have positive outcomes. So the reason why I'm stressing on this is just saying, I got the sample, I did it, I gave, I informed. My job is done. No. Did you receive the sample properly? Did you accept the sample fast? Did you process it fast? Did you inform them? Even if you have not found them, did you make an effort to go and find out and inform them? Did you release it on time? Did they call to the doctor immediately? Only when we are proactive, then it is called collaborative efforts. So in order for us to have this, we need to keep talking to the ICU people, the emergency people, the ward people. Look, whenever you get a sample, put a red sticker. Don't forget to put a red sticker. Keep reminding them. Whenever you find a critical value and you find that there is no red sticker, call them. Tell them to put a red sticker. So that is how we are collaborating and increasing our efficiency. Okay, they didn't send a red sticker. We didn't know we sent it. These are just excuses. So in umpteen number of ways, we can make a difference to patient. Now, what are the common critical panic values in healthcare? So let me go into elevated blood glucose. As I told you, he can go into ketoacidosis. Abnormal electrolytes, potassium, very high potassium, cardiac arrhythmias, severe anemia, liver enzymes, ammonia, high ammonia values. All these will trigger a sequence of cascade of events inside the patient's body, and that will lead to him becoming even more critical. These are some of the common ones. Now, why did I say these are common? Ammonia. Normally, you don't find ammonia because converted to urea. But when the liver is not working properly, the ammonia levels become so high, it starts damaging the brain. Amylase, lipase, pancreas is gone. And the moment amylase, lipase, then a cascading effect of damage to the cells happen. So that is the reason why we need to start panicking. Literally, we need to panic and report the critical values. Now in hematology, in biochemistry, glucose, I told you, arterial PCO2, sodium, serum potassium. I've already told you all about all these things. So if normal is 65 to 110, critical is more than 450. So you need to know what is this critical value. You need to know when to say it is critical. And for that, we need to define them properly. Calcium, one more parameter, more than 13. Phosphorus, less than 1.1. Sodium, more than 155. It is highly impossible for any one of us to remember all the ranges for different ages, different sex. So best is to have an electronic media to alert you, okay, for this age, for this sex, this is the normal value and this is the critical high value. So we make a list of all the values and we enter it in the system, and anything which crosses this value, anything this crosses less than this or it is higher than this, then we label it as critical values. Now, not only biochemistry has critical values, even you have under hormones, you have hematology. Imagine hemoglobin more than 20. If a white cell count is more than 30,000, 100% that person is having infection. He will go into septicemia. Platelets less than 20,000, less than 10,000. We need to act. And how do we act? WBC count more, we need to give them antibiotics. If platelets count are there, we need to infuse platelets. So it's not only in biochemistry that you have critical alerts, you also have critical alerts in hematology. In urine, whenever there's black urine, that means there is hemolysis somewhere. And it's giving an indication that something is happening inside. Serology values, there are so many panic values wherein it is, we need to send out. Like, say, hanging drop. It's critical. CSF fluid, glucose, protein, WBC. So we need to understand what is the specimen, what is the department, and what are the values. Department, specimen, values. Department, specimen, values. Every department, every specimen, every thing has something called normal, critical, high, critical. That you should be aware of. Microbiology, gram stain, if positive. Blood cultures, positive. Bone marrow smear, positive for malaria, leishmaniasis. So every section has critical values. We only think about biochemistry. No. Microbiology, hematology, everywhere it is there. Amniotic fluid. Suppose the baby is in fetal distress. The color of the amniotic fluid, the bilirubin levels, everything matters. Then once you see that, you need to document and report it. As I mentioned, name of the patient, age of the patient, which ward is coming from, what is the value, who did you report it to, what time did you report, and when you told them the value, did he tell us the value back? Did he hear it properly? So all these things have to be documented. And only when it is documented properly, we'll be able to trace tomorrow, okay, this sample came in at this time. We gave the report at this time. We told the doctors at this time. Then we know that we have taken 1 hour, half an hour, 45 minutes. Suppose we don't document, how will we know when did we release out of the 1,000 reports? And when we find that there is something like more than 1 hour it's taking and we haven't reported, then we go and ask the technician what happened. Normally you do it properly, but what happened? Ma'am, there were so many emergency samples. Then what do? You need to have extra staff over there the moment you realize that more number of samples. There are times when a lot of patients come with MI suddenly. There'll be one phase in the year where every night you have 10 troponins, 20 troponins coming in. Sometimes there won't even be one. So if you document it and you see it over the year, what are the trends? Which months you are finding more MIs? Then you can move the people from normal shifts to that area and the time in the night so that there is somebody out there to help this person doing. While he's analyzing, maybe he can call and tell. That is why we need to document, and document in such a way that we are able to improve. And what is the format? I've removed the name and age and sex and hospital number. I've just kept a thing so that you know what time it is collected, what time we received it, what was the critical values, what are the units, what is the range, what is the readout value. I told you about readout value. When you inform somebody, you need to ask them to read it out. Did they hear it properly? And informed to whom? And informed by. Who did you tell? And who informed? Like suppose I have informed by Dr. Shailaja to Nadia, the nurse Nadia in the ward. And what time did you inform? And then from the time the sample came to the time the sample we reported, that is the time when we realize, can we make it lesser? We'll start thinking of ways in which we can improve ourselves. If we don't document it, we will never know where we stand. Okay, all of you all till now, how many of you all have understood this concept? Type in the chat box, yes or no. If yes, type in yes. The importance of critical values, how you tell people what to document, why we need to document. And not only biochemistry, you have hematology, you have microbiology, everywhere you have critical alerts. And for us to identify critical alerts, our QC should be absolutely correct. Only then the correct value is coming, and that correct value is to the biological reference interval is correct. Keeping that, you say high or low for the age and sex. Correct? Clear till now? Next. As I told you, importance of timely communication and follow-up. We have informed. And then, if you have a EMR solution, go and see whether the doctor has treated the patients properly on time. If suppose you have found that action has not been taken, find out, sir, we called and we told your staff and you, was there any reason why the patient has not been able to, why you were not able to put the patient on treatment? And he might come up with something that, yes, you informed the nurse, but I did not get it from the nurse. Then what you say, okay, sir, next time onwards, can we have your mobile number or message so that do we have your permission to send you messages? So, when we start communicating, when we start following up, we will find ways and means in which we can reach out and ensure that this communication information reaches the right person at the right time so that they can act immediately. All of you all understood to what extent we have to go. If it was our family, won't we do that? Exactly. So that's what I was coming to, timely communication. How do we alert? I said red color can be there. Then how do we route it from lab to nurse to doctor who has been assigned to the patient? Then how it is delivered? By WhatsApp, by computers, by calls, and acknowledging the other person, acknowledging that he has got it. So that is how we ensure we communicate it at the right time because it is critical and action can be taken. So when we get critical samples, emergency samples, check the report the moment the values are high, note the ward and extension number, immediately inform the relevant ward, ICU, MICU, or EMD. It need not be only from ICUs, it could be from the wards also. So check whether it is from the wards and then document the following date and time. When you notified, who did you call, person to whom the result was communicated, and the lab personnel who communicated the result and the time. This, if you document, it becomes very clear that we have acted within the time frame in which it is possible to deliver reports. So you can go to one more. Suppose a pop-up message on your mobile, or suppose a beep sound, or a text, like I said, your message text, automated phone calls. There are numerous electronic gadgets are umpteen nowadays. So according to your hospital, according to what you feel is a right way of going for it, think about something that will work. Think about something that is practical. Identify which are the communication channel and start going. Next, if it is in the LIS, then red color, all emergencies come in red. So the moment you see on the screen red, 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 immediately save, immediately receive, immediately put. Plus on the tube, there's a red sticker. So even in the computers, you can start having alerts. Then again, we only in the lab doing our work is not sufficient. We have to integrate our critical alerts with the mobile devices of clinicians. So the one step ahead is the moment critical alert is there in an EMR, and we know that EMR, we know which doctor is treating the patient. We know the doctor's mobile number. Then we make this integration in such a way, critical alert, doctor, his mobile, message goes in with a beep. Simple. All critical alerts, whoever is a doctor on duty, if a duty roster is there, then link the duty roster to the critical alerts, and we can put, with technology, you can do so many things. And then you can also ensure that we have escalation matrix. Suppose the critical alert is just at the borderline, then maybe the associate professor or professor can be addressed. Suppose very, very high, you can ask the doctor, whom should I inform? And then in that system only, it can be alerted to the next level. And clear and quick understanding of how it works and prompt action. So in order to have all this, you need to have an SOP. And who you will give, when you will give, what you will tell, how you will tell. And that SOP should be very, very clear. Otherwise, imagine you are not on duty and you're sleeping and every time a beep comes. It is very irritating. So you have to have the right protocol, the right person who's right treatment, the alert should go to that person. And like I said, escalation level 1, escalation level 2, when and who you have to inform. Clear till now? And then in your LIS also, critical low, critical high. This is when you're watching, when you're releasing the report only, you can make out. It becomes so simple. Oh, it's red color. Now I have to call. And then immediately you call and you write, enter. You called at so-and-so person at so-and-so time, enter and release. How simple it becomes. Otherwise, if you have to see, okay, this range is high or this range is low or this range is thing, it's very, very difficult. So that is how we can improve our services. How many of you all till now have understood the ways and means in which you can type in the chat box now? If you've understood, say yes. If you've not understood, I want to see a no. Understood the way we need to channel our thoughts and how do we ensure that the message reaches the right person at the right time for him to take the right action and help the patient. What happened? Everybody sleeping? I can see only a few S's. Somebody didn't understand? I want it to be more interactive. Is there something that you didn't understand? Okay. So if somebody is not understood, I'll take the questions at the end and then I will repeat whichever area it is. Okay. So how do we monitor and track this time? I told you, if we document it, we know when it came and when. Time of response, when, and we go back and see whether the doctor has treated that time of response. And alert fatigue. Too many critical alerts, then you don't take it seriously. That is when you have to visualize the patient. The moment we visualize a patient on the other side, all our fatigue will go off. And if you visualize one of our family there, absolutely there will be no fatigue. So we need to be alert. We need to respond very, very, what should I say, proactively. And we have to ensure that the patient gets his treatment fast. Can you see? Troponin. Immediately, what was the value? What is it? Who was reported? 1 hour turnaround time, and try and ensure that it is less than 1 hour also. And then go and talk to people. Where did we go wrong? How do we improve? Recently, we had some instances where we were analyzing, and then because the value was high and then diluting, and then we were releasing the report a little later. Suddenly, it did strike me till one day, one patient, even that 1 hour was very crucial. Then I read, it is anyway high. Why does he need a dilution? Release a report saying high, then afterwards we'll think about dilution. It doesn't need. Troponins don't need. A high is a high. So that is how, when we start going down, talking to the clinician, seeing how the patient progresses, and then thinking about how we can reduce, then I sent out a communication. Now, for all troponins, no dilution and final value required. If it's high, just release high. Anyway, the treatment is going to be the same. That way, we reduce the time in which we could report. Clinicians' feedback. I got a feedback from the clinicians. And that is how you optimize the system based on the data that we have and how we. Now, what is the emergency response? Immediate action, alerting the care team, and documenting and reporting. This is what we need to do. Immediately, we need to act. Then after we finish, we alert them, and then we document and we report everything. Now, what is the conclusion and key takeaways? Vigilant, respond, communicate. As a team, we collaborate and refine our protocols, ensuring patient care. Then, and only then, are we doing justice for the word critical and for the word alert. So, critical alerts are essential for effective patient care, but they are challenges. So we need to think about electronic alerts, collaborative efforts that can help mitigate these challenges, use technology, and detection of critical alerts is crucial for every patient. Having a nice communication channel between the laboratory and the clinical staff will enhance workflow integration and improve outcomes. That is the key takeaway. Now, I'll unmute all of y'all. Y'all can please unmute yourself. Okay.
Hello, ma'am.
Yes, please.
Yeah, myself, Dr. Swapna, ma'am.
Yes, Swapna, please go ahead.
Content is really good, ma'am. It was so much informative.
Thank you. It's just my years of experience that I put into these webinars so that all of you all will start thinking in these lines. You know, my purpose of these webinars are I'm giving you all a different thought process of how to approach these standard processes. I hope today all of you all have got a different thinking process. If so, type yes, yes, yes.
Yeah, a few things I have, ma'am. Like
Yeah, please
one
go
thing
ahead.
is sources or resources for this classification of critical alerts. May I know what is the sources or resource for this classification of critical alerts? Because I am
Uh,
listening to this for the first time,
TEEDS,
ma'am.
TEEDS.
Okay, that is classification of critical alerts, ma'am.
No, for the ranges. Classification of critical alerts is coming from our medicine books. Because
Okay,
as I
ma'am.
mentioned in the beginning, it is not only lab values.
Yes, ma'am.
It is the critical of the patient. So in critical care medicine, that is how they define class 1, class 2, class 3.
Oh, it's in emergency. Okay, critical
Yes,
care.
yes.
And one more thing, you have suggested about some electronic media where we can use.
Yes.
So anywhere in India, is this applicable, ma'am?
Here, I showed in our hospital, we have all this. It comes like this only. This is
LIS, in
yeah,
LIS.
yeah. It comes as these values. Immediately, we put a red color. We told the software person, please make it red. Emergency.
Okay.
Then critical alerts become red.
After listening to this topic, I thought I'll also have a word with my management in the hospital. So I want to
Yes.
know whether, okay, ma'am.
So
So
the
I think
LIS
LIS
person,
will be,
whoever is doing your software,
yes,
you
ma'am.
can immediately tell them that put a button called start button or emergency button. So the moment the doctors press the button, this becomes red color. So all those samples in the system only we can know it is emergency.
Okay, ma'am.
And second is the red color sticker. So the person who's
Okay.
handling the tubes also, who's not in front of the computer, also knows that it's an emergency. And put
Okay,
that
ma'am.
sticker, not on the cap because they remove the cap, put it on the tube somewhere away from the barcode and the demographics. These are the three. If you put it at barcode, then the barcode won't read, and then the whole test will get delayed because you have to type the demographics manually.
Okay, ma'am. Thank you, ma'am. Thank you so much, ma'am.
You're welcome. Anybody else? Any questions?
Ma'am, I am Dr. Devashish. I'm
Good
asking one
evening,
question.
Devashish. Yeah.
Ma'am, liver enzyme value SGOT, can it be value of 20,000 or something like that?
Yes. You can have very, very high values. Sometimes we have seen very, very high values and dilution with dilutions also because absolutely when we do the correct dilution, but you have to notice when they have such a high value, ammonia values will be very, very high.
Okay.
If it is a liver source. If it is not a liver source, then you have to think about other areas, other sites from which this is coming from. Because it's not only liver, you have other sites from which also values can come up, right?
Okay, ma'am.
But
Madam,
that
in
high
that
value
case,
is usually from the liver.
okay. Ma'am, then what can be that SGPT value in that case?
Yeah, now
If it is
SGOT and
SGOT is
SGPT value, depending on the disease, the ratios are there. For alcoholism, there is one ratio. For cirrhosis, there is a ratio. So whenever you calculate those ratios, then you will be able to pinpoint at the diagnosis. So if you go into, what was that, the book that we have, TEADS is there, one more book. Oh God.
Henry, ma'am.
Not Henry.
Bishop.
Not Bishop. Laboratory interpretation of laboratory tests. There's one more book. I'm not getting the name. There he clearly defines the ratios.
Marshall.
Yeah, Marshall also has it, and in one of the thing, if I remember, I'll put the thing in the WhatsApp group. In that, all ratios are really clearly very well made,
Madam.
mentioned. Yes.
Dr. Smellish.
Okay, ma'am. Thank you, ma'am.
Any other questions?
Hello, ma'am.
Yeah.
Yes, ma'am. This is Dr. Reshma.
Hi,
Yeah,
Reshma.
I wanted to know, yes, ma'am, what is the scenario in case of standalone labs with critical alerts? Because
Yeah,
this is a hospital
that-
setup, it's a different.
Really, I mean, normally everybody says, oh, this is a wonderful question, but actually it's a wonderful question. See, we also send out samples to outside labs. Now, the moment they find that the value is high, but very, very clearly we have told them, this is my lab manager's number.
Mhm.
You need to call and tell us that the value is high. So always know that your lab, which is processing, and one more thing, what we are doing is we are sending out samples where the samples are done there. They are not in turn sending it outside.
Mhm.
So if they're doing it there, we send it there. If they're not doing it there, we as well tie up with the person who's doing it. Because of this situation where we are able to get them to inform us immediately about very, very high values.
Okay.
So that is a mechanism. When you're having the MOU, when you're tying up with them, tell them these are the numbers, even if it is in the midnight also, even if it is thing, please do let us. Then the process of what you are doing in the lab will continue. Who is the doctor, who is a nurse, which ward, everything that you can continue. But having the mobile number and informing them that they need to let you know is very, very important.
And if you're working in a standalone lab,
Yeah.
we have
Now
to inform
coming to
patient directly.
Yeah, OPD patients. This is all OPD patients, correct?
Yes.
Then what you do is you capture the mobile number.
Mhm.
When you're receiving, ensure that you always capture the mobile number. And immediately put a person to call them and tell them, please come back to the lab. Please come back and go see your doctor immediately. We've informed. Do not reveal the values to the patient because some doctors don't like it. There was an instance when one of our technicians called the patient and told them you have very high values. That patient panicked and came. And then the doctor said, please do not inform them directly. Tell me and I will call them.
Okay.
So find out from the doctor whether the information you would want them to give it to the patient directly or to the treating physician first.
So we don't reveal the values.
Yes, yes. Sometimes what happens, the patients don't know the seriousness and we don't know the treatment that they are undergoing.
Treatment. Yes.
So what happens, sometimes their values are very, very high. And now this is after treatment, the value is low. And then we call them and we tell them it is very, very high. Oh, doctor, you said my treatment is coming down and the lab is telling the values are very high. But comparatively, it has come down.
Yes.
But that context is, we don't know the context. For us, it's very high. But for the doctor, the values are coming down.
Yes, ma'am.
So-
And one more question, ma'am. If is TEADS as a source is enough, or do we have to consult with the physicians regarding the finalizing the critical value alert?
I'm sticking to TEADS because the biological reference intervals and everything they have done for a huge population. We haven't done any studies that can give us the reference intervals for our population. And I leave it to the clinician because every clinician has his own way of interpreting. It's up to them. But tomorrow, if we have to show them from where did you get this documentation, then we need to have either a guideline, which is out there, which is everybody's accepting, or a textbook, which we have to refer to.
Okay.
Ma'am, is there
How
any
they want to
particular
interpret, how they want to interpret it going forward, we can't cater to everybody's whims and fancies. This is what we are going to. Once a value comes, you interpret it however you want.
Okay. Okay. Yes. Thank you.
Ma'am, is there any particular edition of TEADS which is preferable in already?
Always the
Latest is the good.
Yes.
Okay, ma'am.
And one more thing, we don't have to keep on buying TEADS. Suppose somebody has a TEADS thing, and then you just ask them to Xerox, give you all the biological reference interval pages, the whole set.
Okay.
And then you map it with that edition to this edition. Recently, there were some changes in the values. So when that happens, because of technology, because of data, because of so many studies going on, they are also revising the biological reference intervals. That time you need to put it into your system so that it is updated. And not only do you put it into the system, you also tell the clinicians now. Because suddenly they are used to one value and suddenly for that value you're telling it's high or low. They will say, what's happening? Why are you all changing everything? So call for a meeting, tell all the doctors, sir, now the standards have changed, the values are thing. So we are updating our values in our system. So now you will find different high, low, critical high, critical low. So warn them. Even sometimes you are changing one methodology of units. When you change the units also, sometimes it is 20,000 and suddenly you're giving 200. Nobody look at the units. In such instances, we need to communicate to everybody. We don't know who's ordering the tests. Or in the report, you can put, highlight it and put, sir, we have used a different method where the units are changed. So please interpret this way. You're used to interpreting it this way. I remember during COVID, D-dimer and all that, you know, when kits were shortage, we had to go by other kits where the units are different. We had to do it. Anybody else? Any question? I want a small favor from all of you all. Can you all write down in the chat box what are your key takeaways? Please type down what were your key takeaways, 3 points, 4 points in the chat box, please. Key points. And do spread this about webinars because every week I would be taking on a different topic, throwing light on what has been my experience in the past 30 years with the intention that it will give you all the insights that I've had. Yeah. Yes. Yes. Thank you. Any other questions? Right. If that's it, we'll end the webinar. Thank you all for taking the time out and coming. I love teaching. It's my passion. So on a Tuesday evening, anything for patient care, anything for, I'm always open to ideas. Whatever innovative ideas that you all have taken, please be free to share it with everybody so that at the end of it, patients benefit. Thank you all. Good night. Have a wonderful evening.
Thank you.
Thank you.